Dean, welcome to our colleagues in Preston. It gives me a great honour to introduce now Professor Hugh Alberti, so a slight amendment to the programme. Hugh will be Professor from the 1st of August, so we're delighted to hear that. Hugh is Sub-Dean for Primary and Community Care at the School of Medical Sciences at Newcastle University and Head of GP Training across the North East region. We've got a lot of his students here, which is fantastic. Hugh is a lead of a 20-strong GP education group and GP partner in Middlesbrough, my hometown, so it's nice to have a fellow smoggy here. And Hugh has the finest collection of colourful socks I've ever seen, and we were really hoping he was going to have them today, but unfortunately he's let us down. But we're hoping that we'll have a brilliant talk regardless. So I'm going to hand over to Hugh. Please remember that we have the VVox app that you can use to submit any of your questions, and you can also ask us live, so I'll hand straight over.
Thank you very much indeed, Gabs. And morning, everyone here in Aberdeen and those of you in Preston. It's interesting to remember, isn't it, that 3 years ago, it would have been really novel to be stood here and talking to people in a different town. Whereas now, today, actually, the novelty is actually there's people in the same room as me, which is great. So fantastic to see faces as well as screens around. And I just want to first start by saying a massive thank you to the organising committees of both SAPC and ASME, because some of us have been pushing for more collaboration and cooperation, those of us who are GP educationalists, so we kind of span both organisations. So a massive thank you for putting this morning together. And I guess it serves me right to be invited to speak because I've been pushing for it for so long. So thank you very much indeed for that. One of the organising committee members challenged me to talk about what undergraduate general practice education has to offer. So that's my challenge this morning, to try and present what I believe undergraduate general practice education has to offer you as medical educationalists in this room and you as academic primary care researchers in Preston. And I'm sure those of you who know me will tell me, give me some very positive feedback as to whether I've succeeded or not. But I want to start with a few of my patients. So these are a few other smoggies from Middlesbrough that I've seen recently. And although I told every one of them that I would be speaking soon to roomfuls of clever academics from around the country and even from further, do you know what? Not one of them was interested or that bothered at all. And maybe think, actually, what do they want? Well, tying in a little bit cleverly with what Joanne was talking, I believe actually what they want of me and is of our future doctors is that we are caring and knowledgeable. And that actually matters more to them. However honoured I feel to be here, that matters a lot more to them. And I will just give an apology and a warning, because I may tread on some toes this morning. The views I express are completely my own and not those of my employers, or indeed of my fantastic team of lecturers and teaching fellows and trainees whose work I'll be presenting this morning. And as a good generalist, I'll be covering a lot of ground, but not in that much detail. I'll obviously be doing it with great knowledge and scholarship because I've been listening to the last talk. But if I just pay lip service to an area that you're a complete expert in, then apologies, but there's quite a lot of ground that I want to cover. I'm also hoping to be just a little bit thought-provoking and provocative, and also just a reminder that I may well be wrong about some of what I say. So I want to look at undergraduate general practice education. Where's it come from, briefly? Where are we up to now? And where are we going? Now, as we age, we become part of history. So it would be very tempting to prolong this first section, but just 2 slides, that's all to sum it up. And this is a quote from Nigel Oswald, who actually happened to be my first academic boss when he was professor at Teesside in Newcastle in the 1990s. And I think it might be fair to say that until recently, this kind of sums up well what the last couple of hundreds years have been like in medical education. So is this changing, is the question. Well, it's a reminder really that it's only been relatively recently, it depends how old you are, whether something's relative and recent, but for me I feel it's relatively recently that general practice has been part of undergraduate education. So in 1948, when the NHS was set up, across the UK, there was no mention of general practice linked to medical education at all. Although coincidentally, that same year, Richard Scott in Edinburgh was setting up the first university practice, then followed with the first academic unit. Manchester started with a centre in the 1950s. Others slowly continued, but still in the 60s, 70s, still only half of medical schools had a mandatory GP placement. And that only really changed in the 90s, which I realize some of you may well have been born in the 90s, but for me still, sorry, that's still quite recent. And this is a graph from a collection of surveys that have been done over the last 50 years, showing a steady increase in the percentage of time that students spend in GP placements, which has basically been growing rapidly until about 10, 15 years ago. And the last survey actually showed it had plateaued or even decreased a little. However, we know that a lot of schools, like us at Newcastle and others, have very recently had a massive increase in GP time, and a lot of the new medical schools have more GP time than some of the historic ones. And in fact, the last survey that we did 3 or 4 years ago, half of medical schools were expecting to increase their GP time in the near future. So I think when we do the next survey, I think that will have gone up again. So that's very, very briefly where we've come from. Just a reminder, it's relatively recent. Where are we now? Well, Sophie Park, who will be sitting in Preston, and her colleagues published a seminal piece of work in which they synthesized the research to date of undergraduate medical education in general practice in the UK. So compared to hospital settings, students learnt clinical skills as well or better, they received more teaching, and they consulted with more patients. But key to their findings, I think, was this figure here, which demonstrates the GP as the broker in this relationship between the student and the patient. And so you have the patient here with a legitimate membership in the community of practice within the teaching triad that we're trying to develop. We're trying to reduce the power hierarchies. And then you have the student here. And the key here is the active and meaningful participation in this triad relationship. As well as this model they developed, they highlighted that general practice was indeed a socio-cultural learning space. And they described the fact that students felt a tension between the real world of medical training in general practice with patients and the textbook medicine that was offered often in the hospital setting, in which students felt dominated their exams and their assessments. Now, one of our own team in Newcastle, Dorian Ilawa, is just finishing a doctorate she's doing where she's looked at the patient involvement and their perceptions of their involvement in teaching in general practice. And firstly, she found that, as I think many of us know, most patients, most of the time, are very happy to see students with or without the clinician. And there are certain groups with certain problems where that's not always the case, but generally speaking, they're very positive about being involved. And interestingly, her findings, which were from surveys and from focus groups and from co-created workshops we did, mostly with patients, came up with a similar model to Park's model before, where again, you have here the tutor, the GP at the bottom, but facilitating this relationship between the patient and the student. And here the patient is offering to the student not just teaching and learning opportunities, but some support and some feedback. So again, the key here is this triad relationship and meaningful participation and active participation of every one of the players, with the GP, the teacher, facilitating this relationship. So what do we actually teach in general practice? Well, a team from Bristol a few years ago reviewed all the curriculum documents in the medical schools at that time nationally, and came up with a huge list of stuff that we teach, both from the ICGP curriculum, but also other bits. Now, I've purposely put that on one slide, knowing that most of you from the back, especially if you're my age, won't actually be able to read it, which I guess is the point. There's masses of stuff. And in fact, actually, maybe the question's the wrong way round. What could we actually not teach in general practice? Well, surgery, I'll certainly give you that. Anesthetics, some aspects of specialty care, how to take notes on a ward round. but I wonder how much else. And then what do these students actually do when they're on their GP placements? Well, this is a word cloud of feedback from some of our final year students following their GP placement of the things that they valued from their placement. And it's really nice to see, obviously you've got practice there, it's quite nice to see patients, quite large, isn't it? I was happy with that. And learning, that's good job as well. But as well here, you've got parallel and surgeries. And these are these student-led surgeries where the students are relatively independently seeing patients. And that's what they really, really seem to value from their placements. But interestingly, there's very, very little research that's been done on exploring student-led surgeries, what students learn, how they learn it, where the learning is actually taking place, how can we best facilitate those opportunities for the students. We predictably have started to do a little bit of work to explore this, and this is one model that we came up with, which talks about the bridging the gap for the student down here to becoming a doctor. And there's these steps that they could take, increasing their skill, their responsibility, their knowledge, to them becoming more and more independent and confident and taking the role of a doctor. And it seems that's what these authentic placements and authentic experience of students being the doctor seem to be absolutely key for the students and for their learning opportunities. So in fact, are we actually moving back more to like an apprenticeship model of training rather than stuffing knowledge into their heads of students for 2 years about science and then suddenly remembering that they've got to see some patients at some point? What about meaningful participation? So some of the enablers, some of the things that the students and in fact the tutors talked about that enabled students to bridge this gap was the student playing the active role of being a practitioner, active learning, doing, but also having ownership of patients and a legitimate input that they can actually be useful and actually help with the management of patients. How can we facilitate this? Does this lead on to entrustable decision-making and entrustable professional activities? Do we need more of those within our undergraduate curricula? So what about other aspects of GP placements? I could have just taken a video from downstairs, couldn't I? Because certainly here in Aberdeen, there's a big graduation going on downstairs, which I got confused about when I first arrived this morning. But what do we know about GP placements and how they influence future career choice, which is obviously crucial for workforce planning in our healthcare systems? Well, we've shown a small but significant relationship between the quantity of exposure of students to authentic GP teaching at medical school and the subsequent proportion of students from those medical schools who then enter directly into GP training, suggesting that stuff that we do at medical school is important. But we know there's lots of other factors, and there's lots of other things that influence students' choice of whether they want to become a GP or not. The media and outside factors are very strong motivators. And interestingly, in most studies, very few first-year medical students have GP as one of their career choices, which makes you think, well, what's that about? Are we actually recruiting, selecting the wrong students, maybe? Work-life balance is another debatable issue, whatever it means. It's often talked about, but what does that actually mean? And is actually that true nowadays with the current clinical climate that we're in? Is it historical, linking back to Nigel Oswald's comments that I quoted before? Is it still seen as an add-on or as a poorer cousin compared to our secondary care colleagues? Or is it actually the job? Is it just a less popular option than working on the wards or in surgery? And how has the effect of COVID and the massive increase of remote and telephone consulting, how is that going to be influencing students and trainees considering general practice as a career? We know role modeling is really important. 90% of students talk about the GP tutor as being one of their key factors of why they would think about general practice as a career. And we're looking into that a bit further on and finding out what that means and how can we develop good role models. Intellectual stimulation. This might answer one of the questions that Joanne answered earlier. So we know from the Destination GP survey that I'll mention in a minute, only 3% of medical students saw general practice as intellectually challenging. But qualitative work that we've done with colleagues from Canada actually show it's much, much more nuanced than that. And actually students view the challenge of being a GP as being associated with problem solving, with clinical uncertainty, and the challenge of having to know something about everything. However, the other finding we found was that many students had never heard or come across academic general practice or academic family medicine. So I guess my challenge, particularly for those watching in Preston, is if you're primary care research, doing primary care research, do students know you exist and know what you're doing? And if not, why not? And then finally, just a GP. I'm just a GP. I'm going to become just a GP. This is a cartoon from an Australian GP called Doc Rat. But more seriously, we and others have looked at the issue of whether you want to call it banter or whether you want to call it unprofessional derogatory comments about general practice as a career choice. And it's an important issue because it does influence students and their preference for career choice. We've been asking students and foundation doctors and even GP trainees over the last 5 years about whether they've heard negative comments mostly from clinicians or from other medical school people about GP as a career choice. And sadly, there's a consistent and not reducing yet proportion minority of students who are still saying they're hearing negative comments about general practice as a career choice. So is this a professionalism issue that we need to have a zero tolerance to? On a more positive note, we know that one positive influence on career choice is involving postgraduate trainees in teaching students in general practice. And we and others have done quite a lot of work on this and come up with this strapline, which is really that everyone's a winner out of it. Students like it, they value it, and there's also some good educational theory around zone of proximal development, near peer teaching that would support it. Trainees like it, it's part of their mandatory curriculum, certainly for GP trainees. Medical schools like it because it increases our capacity for teaching, and for practices, it actually spreads out the workload of the teaching. And in fact, 90% of trainees in one of our surveys said that they would see themselves as being a teacher in the future as a GP, and yet the minority had had any experience at all as a trainee of teaching students. So why is this? Well, one study we looked at came up with this model, and there were some obvious practical issues around the trainees and maybe their focus on exams rather than on teaching. Teaching issues, our teaching is very much patient-based, and sometimes that can be a bit of a challenge for early trainees. Practice issues around space and around workload. But underlying all of this seemed to be an issue of the underlying theme of the culture of general practice not being supportive to teaching. And teaching was here seen sometimes as a deviation from the norm, as an extraneous activity rather than a fundamental part of general practice. So if we want to see general practice, as Parker et al. Talked about, being a socio-cultural learning space, well, what's the problem? Why is it that not all general practices teach students and teach trainees? And finally, medical school culture. What's that like? Well, this is Destination GP, a survey I just mentioned recently, designed by the RCGP and the MSc put together. And in it, they showed that half of students felt there was a positive culture in their medical school towards general practice. But worryingly, over a quarter reported a negative culture. Again, we've done some, or currently doing some qualitative work, which again has showed it's a lot more nuanced than that. I'm presenting this afternoon for those of you who are in Aberdeen if you want to know more. But speaking to GP leaders and medical schools shows there's actually a kaleidoscope of attitudes towards general practice in medical schools. They talk about interactions and language and behavior and the norms that indicate some of these underlying cultural attitudes. Leadership was identified as particularly important in medical school culture, with participants believing that leaders set the tone for medical schools in both their decision-making and their role modeling. And then the GP leaders describe this spectrum of attitudes within and even between different medical schools across the country, from overt denigration sometimes to underlying hidden curriculum issues and an othering of general practice, to actually much more positive examples of valuing of general practice. And there was a feel that through the COVID pandemic, that the valuing of general practice did increase because of the opportunities that we had to showcase the strengths of general practice. And sadly, tensions, hierarchy, and conflict between general practice and generalism and specialties and specialism still continue to be a recurring theme. And surely it's time for this just to stop and for mutual respect to take over. So finally, where are we going? What are the implications of what I've been saying for the future? Well, there's no doubt that one feature of medical education is already, and will only grow, LICs, or longitudinal integrated clerkships, in which teaching clinical placements occurs simultaneously, like it would at school, rather than in traditional block placements. And early research from rural Australia and from Harvard, but now growing research from this country as well as other countries internationally, have shown that there are benefits here for the students, both academically and professionally, that there are benefits for teachers, but there's also uniquely benefits for patients. So Alistair Dodsworth, who's in the audience, is halfway through his doctorate teaching at Newcastle, where he's studying the LIC that we have for all of our students across the whole of Year 4. And although we need more research, his systematic review suggests that patients benefit from building from LICs by building a strong relationship with their patients here, and then acting as an agent of change for the patients. So it really is quite novel that we have here an educational innovation that is beneficial for the students, but also beneficial potentially for our patients as well. And surely this will be a part of the future of certainly undergraduate and maybe other aspects of medical education. One key feature of LICs, or LICs as others call it, is the panel of patients that each student has, who they follow up and build a relationship with and follow in and out of primary and secondary care. Now, this isn't a new idea. Some of you, if you're older than me, you may have heard of a Professor Alberti from Newcastle University, who was around quite a while ago. He wasn't a GP, wasn't even an educationalist, but don't tell him I said that. But he talked about this idea. This was in the 90s. So 30 years later on, to be honest with you, we haven't really conquered it yet. We haven't really worked out practically and feasibly how we can enable all of our students to be following patients, accompanying patients in different contexts in the community and in the hospitals. And surely this is something that we need to conquer. Thinking more broadly about the shape of community-based teaching and learning, we've done some work with one of my colleagues based on interviews, again, with GP curriculum leaders from around the country, looking at what the future of undergraduate education might look like, particularly in primary care. And it will certainly include more blended learning models, such as hybrid models. It will certainly include more telemedicine, including virtual surgeries that friends and colleagues of mine are doing here in Aberdeen and in Leeds and other places. The feeling was that it will involve more collaboration and more networking across the country and across specialties, which is fantastic. And again, talked about more student involvement, which again links in with the triadic relationship that I was talking about right at the beginning. So what does the landscape look like? Well, others here, and impressed, are much more qualified than I to predict what the future will look like. But it will be different. We definitely know that. And I believe for us in undergraduate general practice teaching, one fundamental issue that we need to conquer is to increase the capacity of primary care to take on not only increasing numbers of medical students, but increasing number of all healthcare professional students. In most areas of the country, we are at, or sometimes just beyond, maximum capacity for what our volunteer practices will take. So maybe there is something fundamentally wrong with the current system in primary care that means that not all practices are choosing to be these socio-cultural learning spaces that we've been talking about. And finally, can I just leave you with a few other unanswered questions that we would like your help, both as educationalists and as primary care researchers, to answer. How much time in primary and secondary care, how much time in secondary care placements do students actually need? And are integrated placements the answer? How do we increase the capacity in general practice? Do we need a major cultural shift? Do we just need a few different new models? Or do we need a whole new structure for primary care? What actually is the best learning place, the best learning context, the best learning stuff to be doing on our GP placements? Is it these student-led surgeries? And if so, what and where is the learning taking place? How do we best incorporate TEL into our primary care teaching? In fact, not just how, but when and where and how. As I've said, longitudinal placements, I believe, are going to be the mainstay of future curricula. But if there is a place still for some block placements, when and where should they be occurring? And how do we foster this mutual respect across specialties and across disciplines? So please help us to answer these questions, wherever you may be sat, for the sake of our patients who want and need caring and knowledgeable doctors. Thank you very much for your attention.
Lots of questions for you, Hugh.
Oh dear.
So the first one, I think we might have Jill Thistlethwaite here with us in Aberdeen. What's happening with longitudinal GP placements? How long is optimal for trust, team membership and career influencing?
So what was the, how long is the optimum? Yeah. So we reckon there are about half of medical schools in the UK have some sort of longitudinal placements. There are those who are the theorists, and there are even different types that you can classify them into. And it's one of those where I think actually the more pure it can be, the better, because actually one thing we don't yet know is from longitudinal placements, where's the benefit coming from? Is it coming from these relationships that students are building with 3 or 4 different tutors? Is it coming from the relationship with this panel of patients? Is it being part of one team continually? Is it the learning? We know the learning is based on very good education psychological theory, that integrated learning over a long time means they maintain it more. So actually what we really need to answer that question is more research to find out actually what other elements, or do we just need to do all of it? Can't actually remember what the question was, but does that sort of answer it?
I think that's a good try. So we've now got Nero Amin. How do you think the new ICS structures will impact UG teaching?
Very interesting. So I haven't trod on any toes regarding training hubs or PCNs, etc. I suppose my view, and maybe it's just because I'm old, so I even remember PCGs and before PCGs, is that all these different models and groupings haven't yet shown me that there's any increased capacity for students. I haven't seen any evidence that a group, whether it be a PCN or whether it be a training hub, will take more of my students than the individual practices. Now, I very much would like to be proved wrong, and I guess I suppose my current position with ICS is let's see what happens. I don't see that radically changing things yet, but again, I might be proved to be wrong.
Thank you. Sabina Jamil. We've had LICs for a while. Increasingly, providers are dropping out because they're so busy and cannot commit to these placements. We now do not have enough placements, so LICs are sacrificed. Any ideas how we can promote this in a climate where HCPs are overwhelmed with clinical work and admin backlogs, in addition to being under-resourced?
Absolutely. It's interesting because I think that there are extra challenges with LICs because of this relationship that you're developing between the student and the tutor. And maybe I'm not naive because we've developed it for 370 students across the Northeast, and there have been challenges, and some, I'm not quite answering the question, but the students found it a challenge as well, and they go through this curve of what on earth am I doing to, oh, okay, I can see what we're doing by the end of the year, hopefully. But I do feel that it doesn't necessarily have to be that much harder. It is certainly harder to have 2 students sat in an outpatient clinic or 2 or 4 students in a practice than just having a group that just wander onto the ward and do their own thing. But actually, can I be really provocative and say that we are paid, I shouldn't mention money currently, should I, with the change in the tariffs, but trusts and practices are paid to have students. And that money, I think, should be best used to give the supervisors the time to then be able to supervise the students. Come and shoot me afterwards.
So the next question is from Rupert Payne, who I think is in Preston. As incoming chair of SAPC, I'm somewhat depressed by your comment that most medical students have not heard of academic general practice. I'm very aware that in the university primary care departments, teaching groups often sit in the same building but don't work closely with research colleagues. How can we bridge the gap and ensure that when we teach in general practice, we showcase to students the research and other scholarly activities of our discipline?
Absolutely, a really, really good question, Rupert. And yes, it is a bit depressing. And I think that the change in departments has changed. When we did the recent survey, I think it was only 5 or 6 medical schools said that they sat in the same department of general practice as their research colleagues, and that's a major problem. So I guess it's based a lot of it on relationships. So I have a virtual relationship with the researchers in Newcastle where we communicate, etc. But I guess it goes both ways. For those as educationists, if we think this is important, then we should be reaching out to our primary care research colleagues. Those of you in Preston, I would say, contact your local medical school and say, how can we help? In what way? And now, in the past, it might have just been stood up and do a lecture about X, Y, or Z. But I think there are a lot more nuanced ways that we can be involved, whether it be with SSCs, but then that just means that you've only got students who are particularly interested. But there are other ways that you can be involved, and I just would say get in touch with your local medical school and make it happen.
Our next question is from Tristan Price. UK Med database data suggests that students from WP backgrounds and from state schools are more likely to choose GP as a speciality.
Yeah.
Is this good? With WP programs, will they get more GPs? Or is it bad that certain specialties are linked to a certain demographic?
Interesting. I think it is what it is. And I guess at the same time, I mean, don't get me wrong, those are my other colleagues who are not GPs. Our medical school, we train students to then have the ability to then choose which specialty, general practice or hospital, that they want to go into. And what we're trying to do is just make sure that some specialties, not just ours, but others, aren't disadvantaged. But we want, obviously, we need specialists, we need GPs. So if certainly we have a much increasing number of students from WP backgrounds, and I think others are, and that may make a bit of difference. The other group that's quite interesting to look at are graduates. So graduate entries, students are more likely to become GPs. And actually linking back to LICs, one of the struggles that students have with LICs is that they're very much dependent on the student to go out and work out what they need to know and how they're going to know it. And so certainly in Australia and America, it seems that the graduate entry students that they have do find that easier to do than maybe some of our 20, 21-year-olds. So again, that could be an argument for more graduate entry places at medical school.
Thank you, Hugh. There's lots of unanswered questions, so perhaps we might record you with some of them on Twitter later, because it seems a shame not to hear your answers. But thank you very much.
With pleasure. Thank you very much indeed.